Welcome to the PsychopharmaStahlogy Show, a special NEI Podcast series. In this show, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today.
Hello and welcome to another episode of the NEI Podcast, the PsychopharmaStahlogy Show. And here with me, as always, is the one and only Dr. Stephen Stahl. How you doing today, Steve?
Great, Andy. Great to be here.
Yeah, well, we've got a very interesting topic. This is going to be the first of a series we're doing, and this one is entitled Classic Psychedelics for the Modern Psychopharmacologist, Good or Evil? Well, Steve, let's get started. When we talk about psychedelic drugs, what are we actually talking about? What drugs fall in that category?
Well, a psychedelic experience is induced by a psychedelic drug, and that would be, some sort of enhanced perceptions of time, space, sensory experiences, and even something almost like psychosis. You have close to not so much auditory hallucinations, but visual, at least if not hallucinations. There's a thing called distortions of what's already there, and it's an illusion rather than a hallucination. Those sorts of experiences. But they tend to have a powerful emotional component to it. And people feel that these aren't trivial. They're very meaningful, at least in the sense of the subjective experience of it.
Yeah, a lot of people talk about a mystical experience or a oneness or getting outside of yourself. I wonder if that's a psychological correlate of something that's happening biologically.
Yeah, who knows? I mean, this is sort of the hippie kind of a way of looking at it, too. The oneness with nature, and where you can see your tastes and taste your visions and hear your visions, and it's mixing up with the sensory experiences, and also oneness with the universe, and the idea that you're part of everybody else, and you're part of maybe even a religious type of with God, and these are kinds of dimensions that are described by people who have them. But sometimes they're actually thought to be by the person to be the most significant experience they've ever had.
Yeah, I've heard that. We divide these drugs now. The modern classification is we call them all hallucinogens, and under that rubric, there's the classic psychedelics, which is like psilocybin and LSD and some others, ayahuasca and others. The dissociatives are ketamine, PCP-like drugs. And then the empathogens or the entactogens, that's MDMA or ecstasy. And they're all slightly different, but yeah, like you said, they all have distortions of time, space, perception. And, they're all being studied now for various psychiatric conditions. Why now? Why do you think all of a sudden we're studying these drugs now?
Dissatisfaction with the drugs that are used for certain things and don't work at all. PTSD has no really robust treatments. Most addictions don't. There are treatment-resistant conditions and depression and all sorts of situations. So I think that that idea, and that there's also the idea that something that's a, quote, natural product gets you close to nature, and, this kind of idea that you can take control of your own destiny without really entering the sort of organized medicine space. It has a certain attraction to certain people, just as the cannabis and, movement has.
Yeah, I wonder if the move towards legalization of cannabis has opened a little bit of a door here, along with what you're saying, the dissatisfaction with what we have currently.
I'm sure it has. I think that there's a yearning for the ability to have things work better than conventional treatments, both by providers such as you and me, as well as by patients. There's a certain amount of restlessness, and we've talked a little bit in another podcast about we're entering the third generation of innovation in psychopharmacology, having just left another dark age where there was a large amount of withdrawal of innovation of the large drug companies from the central nervous system out of pessimism that there would be anything else found. And so this made people retrench and look for elsewhere and alternatives, and you could also call this alternative medicine.
That's an interesting way of thinking about it. And I like your formulation about this sort of natural kind of idea, because a lot of these things are, of course, psilocybin comes from mushrooms and things like that. Ayahuasca has been used for centuries. But, the history of this is fascinating. You mentioned the hippies, Steve, and they actually have an important role in this. These drugs, at least LSD and some of the others, were originally developed for therapeutic uses. But of course, with the hippies starting to experiment and use these drugs and tune in and drop out, Congress actually kind of got a little scared and rebelled. And with the FDA Controlled Substances Act, they got thrown into Schedule I, meaning there's no legitimate therapeutic use, which I think is an overreaction.
I think so too. And, they were abandoned after misuse as well as, just no regulation. So, having this movement where people really were trying to do something that was not regulated, created regulations, and maybe it was over-regulated, we don't know, but it was sort of abandoned, and maybe part of that had to do with the misuse of some of this by the CIA, who at the time that these things were regulated, and also psychotherapists, largely actually in California, were giving this, a few doses and seeing if they can induce experiences that would be therapeutic to patients. But the CIA tried to use it to induce confessions or to change others, things that weren't too good. So that got regulated and then thrown into Schedule I.
Yeah, I'm reminded of the Manchurian Candidate.
Yes. So I think the stormy past, we've had a stormy past with this. And actually, I think we have a stormy present, to my own way of looking at the situation.
What do you mean?
Well, I think that there's the idea that the experience, the hallucinatory experience, is the therapeutic driver of everything. And that you have to have this incredible, basically psychedelic experience in order to be cured. And meanwhile, I'm a psychopharmacologist and know that when you give these agents, there is a very robust change in neuroplasticity, or the sprouting of synapses within minutes of ingesting these agents. And that is the final common pathway of a lot of the particularly antidepressant actions of many agents, including ketamine and others. So it is a question: do you want to give a psychedelic experience so that drives therapeutics? Or is this basically psychedelic-assisted psychotherapy? Or are you giving neuroplasticity and the psychedelic experience is a form of behavioral toxicity? And, there's different points of view on this. The enthusiasts believe that the experience is the therapy.
Yeah, of course, the whole rubric, the name, psychedelic-assisted psychotherapy, as if the psychotherapy is important. And I have to tell you, Steve, what's old is new again. One of my mentors, Dr. John Buckman at University of Virginia, was doing some of this early LSD research, and he actually gave LSD to Cary Grant and did psychotherapy. And the thinking was you would unlock the unconscious. So it was a form of biologically assisting the therapy. But as you said, we now know so much more about what's going on here. And, if you think about ketamine, we know that the dissociation is toxicity. That is not necessary for the therapeutic experience. So, it really does beg us to reevaluate this.
Well, it reminds me a little bit about the early days of the antipsychotics, and I think even you were around for those, where it used to be thought that the extrapyramidal symptoms were a marker that you were going to get an antipsychotic experience. And some people even thought that the extrapyramidal experience was actually the cause of the antipsychotic experience. Well, we now know that those two can be dissociated from each other, and that's desirable, and that the antipsychotic experience is the therapeutic one, whereas the motor extrapyramidal experience is a side effect. It occurs at the same time, and often by a similar mechanism. And that's how I actually look at the psychedelic experience, is that it is an interesting byproduct, but that in order to make this a therapeutic that really is traditional in psychiatry, I think we have to be able to give a drug that doesn't cause this behavioral problem and just causes the neuroplasticity. There are going to be drugs that do that. They're in development right now. And that's the grand experiment. What happens if you have the neuroplasticity of the psychedelics mechanism, usually on serotonin receptors, but you don't have the psychedelic experience? Will it work?
We will have to see. You are 100% right, though, Steve. When I trained just before the atypical era, I was trained to push the dose to EPS or to Parkinsonism. That was what we did. So you reminded me of that. Well, Steve, I want to get into this other thought that you're talking about here in a second. But, if we assume most of the studies being done with these agents right now are doing some form of guided experience, psychotherapy, or they'll just have someone in the room with the person. And these trips last, 4 to 6 to 8 hours. So you have to have those people. So logistically, this is going to be quite a challenge if it ever gets implemented.
Right. And psilocybin itself, of course, can't be given a lot of times. So it's just not practical. You're talking about giving 1 or 2 doses, each dose lasting hours. So I don't know the throughput of a therapist's practice, how many of these they can give in a day or in a week in a practice. And the experience, the question is, are you guiding it? Are you shaping it? Are you making it part of the experience that is therapeutic? Or are you just trying to make it so that the behavioral toxicity is not so damaging? Wouldn't it be nice if you could take this agent and not have that? And as you mentioned, well, ketamine causes dissociation. Esketamine causes some dissociation. But you can give a sort of very close to non-dissociating dose that works. And furthermore, a drug which is a combination of dextromethorphan plus bupropion, and even another one which is still in development called S-methadone. These work in the same receptors as the NMDA receptor and don't cause dissociation at all. So it's my point of view that psilocybin is an interesting agent which induces both of these things, neuroplasticity and the hallucinogenic psychedelic experience, and that it may go 2 directions. Here's my predictions. One is that it will go the direction of legalized marijuana, where you basically have psilocybin legalized. I think it's already legal in Oregon and pending in many other states, where you can just give it. And you'll have these sort of experiential clinics that are unregulated, mostly doing psychotherapy and trying to induce these experiences and sort of being off the grid, a little bit of alternative medicine, and maybe practitioners who really believe with that. The other way is to create new drugs that have new patents and actually have a way to induce a plastic experience without a behavioral toxicity experience. And those would probably be drugs you would take more often. And one of the problems nobody really talks about with psilocybin is that one of the reasons that it's a problem with giving it chronically is that it's got 5-HT2B agonism. Well, guess what that does? Exactly. It can cause cardiac valvular problems, just like fenfluramine did. And most of these studies are not doing what you will do would be, problems with monitoring valves, with echocardiograms and so forth. So I don't think that this drug will be approved for, let's say, psilocybin would ever be approved for more than a couple of doses. And but traditionally we have to give our drugs more than that. And so I'm thinking that it's a way into a brand new revolutionary experience of neuroplasticity, but it's probably not itself. I have a hard time believing psilocybins and psychotherapy with it is going to be approved.
Well, of course, as I said, there's going to be significant logistical challenges. First of all, of course, they're currently Schedule 1, and that is a deal breaker for a lot of people because you have to have a special license for that. So they would have to be downward scheduled, if you will, maybe Schedule 2. Then, as you mentioned, you need to have space in your clinic for these people to have this experience all day. You need staff to be guides or even therapists. I think there's going to be a lot of logistical challenges, and I think the way these studies are being done now, I've reviewed a lot of these protocols, that's kind of what they're doing. They're working out this protocol. But to your point, certainly the hallucinogenic experience appears to be agonism at 5-HT2A, the serotonin 2A receptor. But some of these drugs are promiscuous, aren't they, Steve? They bind to other serotonin receptors and they do other things.
Yeah, we really don't know how they work. As you know, psilocybin, we're talking about that one, is metabolized into psilocin, and it can have actions on a plethora of serotonin receptors, 5-HT2C, 5-HT2B, and on. So we don't really know what combination or what single one. The most common is the 5-HT2A receptor, but even having said that, I've told you this before, Andy, in another podcast, most of our drugs in psychiatry are antagonists. Now this is an agonist.
Good point.
We're starting to get into an era of agonist pharmacology, which is a brand new world. And we talked in another podcast about the agonist at muscarinic receptors. Now we're talking about agonist at serotonergic receptors. And guess what? Agonists can work fully or partially, as many of the readers and listeners here are going to know about partial agonists, but they also can cause the signal that's stimulated by the drug to go down different pathways, signal transduction pathways.
Whoa.
And they're used to think, cyclic AMP was it, and you had a nice day, and, that's what it was. But there may be dozens of signal transduction pathways. And some agonists cause some of those to be activated, and other agonists cause others in ways that we don't understand. Now, we call it biased agonism.
Right.
But one of the great hypotheses here, what is it possible that maybe some serotonin 2A agonists activate both a signal transduction pathway that leads to hallucinations and a signal transduction pathway that leads to neuroplasticity? And if that were the case, could one discover, therefore, a signal transduction agent that does one without the other? In other words, that just gives the neuroplasticity without the behavioral changes. And that's actually what's being pursued by people who are more pharmacologically minded. Now, those who are more phenomenologically and psychotherapy minded are saying that, no, you want to actually have, maybe they'd even get rid of the hallucinatory experience and want the opposite drug, one that causes just hallucinations and no neuroplasticity. But the idea is, and this gets into the same thing with the entactogens and the MDMA, ecstasy kinds of agents to create different types of experiences. We are getting results. I mean, there are patients who say they feel better.
Yes.
Now, the problem with assessing results like that are basically subjective. I'm wondering, now, you can tell I'm a little bit of a cynic here, but if you were a true believer and you knew the drug was going to work and you were basically the clinical trial person and the clinician, yes, I believe these drugs work, and you find patients, yes, I know it's going to work, I want to take it because I believe in it, then all of a sudden you put it in the real market and you got cynics like me say, I'm not sure this stuff works, and the patient doesn't really want to take it, but you say, please take it anyway. Is it going to work anymore? Those are called expectancy effects. And then unblinding, because you can't take this drug versus placebo and not know which one you're on. So if you know you're on the drug and you expect it to work, is that going to be only good for people who want to have it work and who expect it to work? What about if you don't want it to work, or if you don't expect it to work, or you're cynical? Will that destroy the therapeutic efficacy? Don't know.
Don't know. Well, I think also another possibility, you mentioned these two extreme sort of scenarios. Another possibility is that, say right now, a derivative of psilocybin is being developed that is patentable. And so maybe this could be something that would be in a clinic, and there could be people who want the psychedelic experience, or there could be people who prefer not to. As you mentioned, there are literally dozens of these so-called second-generation psychedelics being developed that don't cause the hallucinatory or psychedelic experience. And, we didn't mention before, Steve, but some of these drugs have been shown to directly activate BDNF receptors, the TrkB receptor. Isn't that true?
Yes. And that's where the kickoff to neuroplasticity is likely to have occurred. These TRK or TrkB receptors live to actually receive BDNF, brain-derived neurotrophic factor, which then triggers synaptogenesis, new synapse forming. And so it turns out that maybe some 5-HT2A agonists are also TrkB agonists. How about that? And so it would be very interesting if you could take the serotonin part out of it, maybe you'd still have a drug that was really going to work. So, I foresee the possibility that you'll have sort of alternative clinics. You'll have states that allow these things to be used. It'll be a form of unregulated psychotherapy. It will not be FDA approved. The FDA does not license psychotherapies. There's no psychotherapy that's licensed. And so,
Wow.
that is, I think that's where this field is destined to go, unless we find agents that are devoid of the behavioral effects, but do have the neuroplastic effects. That's just me as a cynical person. The other thing is that if you only have 1 or 2 doses that you are taking under the current psychedelic plans with psilocybin, what are you going to charge for that if you're a drug company? $7,500? And so if if they say, well, it takes $15,000 a year to buy a brand new antidepressant or antipsychotic these days, so, and you only take 2 doses for a year, no, we'll charge you $7,500 each and be $15,000 in an afternoon or over 2 weeks. It creates pricing problems. It creates regulatory problems. How are you going to regulate the psychotherapy? How do you license people for that? It won't happen. So I think it will remain unregulated and it'll be on the fringe.
Well, I'm not so sure about that, Steve. There is a company that is actually patenting their protocol. And there are now certification programs for these so-called guides or psychedelic monitors or whatever. So there could be an in-between world. I agree with you that it's probably going to be a real range and some of it will be the Wild West out there. But you point your finger on something else, Steve. These drugs, like ketamine, don't hold a charge forever. Now, they may hold a charge longer than ketamine. There's some studies that suggest weeks to a couple of months. But your point is, and this hasn't been worked out yet, you're probably going to have repeat treatments of some form or other. So, yeah, there's that to work out, and the cost and paying for it and all of that we talked about.
We saw some of that with the recent zuranolone studies, which, by the way, were not approved by the FDA for general depression, but were approved for postpartum. And that was the question, how durable are these effects? And what do you do if they're not durable?
Right.
So in other words, if you respond and then you stop responding, do you re-challenge again? How many times? How long? What if you don't respond? Do you give them a second challenge? So these are questions that we don't understand about the durability of responses, particularly things that respond very quickly but maybe don't last very long. And so that is a brand new world. And when it's talking about outcomes that are not the outcome of the strength or the robustness of the hallucinatory experience, but of the essentially neuroplastic experience, those are 2 different things. We can regulate, I think, something that's a drug that's given daily, but it's going to be very hard to regulate something that is an experience.
Yeah, Steve, I think that sage zuranolone analogy is very apt here because you and I were very involved in the development of that drug, and it was very hard to believe that one treatment, in the case of that one, 2 weeks, could induce some kind of lasting change or rewire the brain. Same thing here. It's sort of hard to imagine that. And I guess some people advocate that the psychotherapy is doing some of this rewiring of the brain and changing the networks. It's just very hard to believe. And almost definitely there'll have to be repeat treatments. But that has to be worked out. Steve, I'm also reminded of the podcast we did previously on neuroplasticity, good or bad, that there's bad neuroplasticity. So how do we ensure that this neuroplasticity we're inducing is healthy?
Well, I guess the question would be, if it's driven by a molecular occupancy of a receptor, we can find out if it's good or bad just by looking at the outcomes. But if it's driven by the fact that you're inducing some sort of behavioral state that is driving the neuroplasticity, then it's going to be much more hard to regulate because, in fact, we don't know what we're doing, quite frankly.
Well, it really is the new frontier, isn't it? We have to talk about our good friend Roger McIntyre is going to be joining us for another podcast in this series. And Roger's recently published a couple of very interesting articles. The first one was a case report his protege Josh Rosenblatt published, and Roger was an author. They were doing a cohort of people with psilocybin for treatment-resistant depression. And one of the 30 people, this one guy, didn't get the psychedelic trip, Steve, and he was pissed because everybody told him how great this trip was. Well, meanwhile, his depression scores plummeted. He had a significant antidepressant effect. And it was only weeks later when this guy said, oh, by the way, I forgot to tell you, I forgot to stop taking my trazodone, which is a 5-HT2A antagonist. So to your earlier point, the psilocybin was doing something else, whether it was biased agonism or binding to another serotonin receptor or the BDNF directly.
Well, he was taking trazodone, right?
Yeah, trazodone, which blocks 5-HT2A. So it blocked perhaps the psychedelic part of the experience.
So maybe the psilocybin is a TrkB agonist and a 5-HT2A agonist. The 5-HT2A would, in that case, drive the hallucinatory experience, but if you blocked it, you wouldn't have the hallucinatory experience, but you'd still have the TrkB agonism causing neuroplasticity and therefore an antidepressant effect. That is consistent with that hypothesis, but doesn't prove it. So it makes you wonder whether or not you do need this so-called experience. I think that a lot of people who are interested in psychotherapy are going to insist that it is the experience. But I don't know if you've seen this, but I've seen patients in my own consultative practice where they come in with a very rich and horrible experience of treatment resistance, and many of whom have had a hallucinatory experience, someone who traveled to the Amazon to get ayahuasca. And they say, oh my God, it was the most incredible experience I ever had. My God, it was life transforming. I saw my dead mother and I, fixed up a lot of problems with, had unfinished business with her and And I say, that's great, but why are you in my office now for your depression? So there was no connecting the dots between that great experience and them getting better from their depression. Right. So it's making me wonder whether or not, yes, it's a great experience for some people and maybe life-altering in some ways, but does that really drive the treatment resistance to go away? And as you can see, I'm skeptical.
Right. Well, like everything else, this has become a little bit political because we're talking about people who have a vested interest. The therapy community, of course, is vested. This is going to be, a moneymaker for them, if you will, or something that they can do and bill for. And so Roger was telling me that this case report that they published, he's getting some pushback from the therapy community. And I think it's reasonable to ask these questions. Is the trip absolutely necessary? And perhaps there'll be some people who you will do that with. We know that our best outcomes with depression are always a combination of medicine and psychotherapy or, lifestyle changes. And maybe that would be one way to do this. And then for people who don't have the time or don't want to do it that way, maybe you just take the medicine and it doesn't cause a psychedelic trip and you still get the antidepressant effect. So there could be a range of experiences and ways of doing this. That's the optimist in me.
Yeah, well, I know that my skepticism towards this being driven by a hallucinatory experience does not mean that I don't think that psychotherapy can also induce neuroplasticity. Psychotherapy is a form of learning. We know that learning induces new synapse formations. And so that, I also believe in synergy. 1 + 1 = 10. Some neuroplasticity driven by learning psychotherapy type experience plus one type of neuroplasticity driven by molecular, mechanisms equals 10 outcomes for therapeutic. So it may be possible to harness some of this. I don't know that, do you need to have a hallucinatory experience or do you need to just do psychotherapy? I mean, psychotherapy doesn't usually have hallucinations associated with it and still can be pretty effective.
Well, that's an excellent point. Steve, a couple of weeks ago, I was in Japan. I was speaking to some Japanese colleagues, and we were talking about new treatments for depression. And something else came up that I thought was very interesting. They were saying, we were talking about psychedelics, and they were saying, we don't want the trip. We don't want the psychedelic experience. The Japanese don't like losing control. They don't like that kind of thing. So it made me think, well, culturally or personality-wise, there are some people who aren't going to want that. There are some who will maybe embrace it.
Well, we'll see. And, I think that there are a group of so-called true believers that really want to have these psychedelic experiences, and they want to believe that they are driving therapeutic outcomes. And I think that if that is the case, and maybe they do, it will be very difficult to approve it as a drug. It'll be probably relegated to a form of psychotherapy, which will be largely unregulated. There's no regulation of psychotherapy, so it could go to that. And again, maybe you'll get this at dispensaries like you get right next to your special forms of cannabis grown in various parts of the world with various type of flavors to them, I guess. It will be a canister of psilocybin.
Yeah, but as I mentioned, there is a company that is patenting a protocol. Now, they're not strictly doing aggressive psychotherapy. It's a protocol around how to monitor people and guide, I guess they call them guides, guide them through the trip. So that might be a way of regulating it, if you will. And, people would have to be certified in order to administer this kind of treatment. But I just think, the evidence suggests, and Roger McIntyre, our friend, just wrote an opinion piece, literally just published this month, September of 2023, really calling into question, is the psychedelic trip essential to this? And he used some of the examples, and he talked about some of the biologic research, the neurobiology of what these drugs do, how we used to think, exactly as you said, that you had to titrate an antipsychotic to Parkinsonism, how the dissociation is not necessary with ketamine. So it's really quite complicated. I think we're entering a new frontier. I think there's also these ethical issues, Steve, that we have to consider. What I can tell you is psychedelics are hot. They are sexy. Everywhere I go, people are asking me about psychedelics.
There's a great hunger for drugs that work, or therapies that work.
Yeah.
And people believe that it's such a dramatic, subjective experience. It's hard to believe for those who've seen it and those who've experienced it that it isn't therapeutic. And so it's basically, in their minds, therapeutic until proven otherwise, rather than saying you have to prove it's therapeutic.
Mm-hmm.
And maybe it is. I mean, it's just going to be very hard to study. I'm a psychopharmacologist, not a psychotherapist. And so,
right.
I think that when you're talking about this field, it is really the field of psychotherapy. It's not the field of psychopharmacology. There may be some lessons we can take from that. We certainly want to have treatments for things that don't work now, and Lord knows we don't treat PTSD very well, and there are lots of people with depression that don't respond to the drugs that we have. So I'm all in favor of anything that works, and nothing disputes the irrefutable logic of results. The question is, if you give 1 or 2 doses of an agent, how are you going to price it? How are you going to test it for toxicity? How are you going to actually administer it? Are you going to require psychotherapy? How are you going to monitor that? It probably is going to have to be not an FDA kind of thing. It's going to have to be a standard of care kind of thing. Because who's going to, what body is going to certify psychotherapists? I can see that training would be a great idea if it's part of the improvement, but there's no body to do that. Maybe people who do psychotherapy can arrogate to themselves the accreditation of psilocybin psychotherapists, but hasn't been done yet.
Well, my concern is also the physiologic monitoring. These drugs are not entirely benign. What if somebody has a so-called bad trip? What if their blood pressure shoots up, like can happen with ketamine or some other kind of experience? If these are being done in an unregulated environment or not a medical clinic or environment, there's a lot of risk here.
Well, the safety is really, if we start talking about the drugs, what are the safeties of this? Part of the problems with the safety of these drugs are the flashbacks. And the idea that you can get a flashback from a drug when the drug's not even there anymore. This was a famous, thing that was, described with the LSD having a lot of flashbacks.
Yes, that's certainly true. So they're not entirely benign. And the trip is not always a pleasant experience necessarily. So there are a lot of things that have to be considered here and regulated. The FDA recently did release a guidance statement on psychedelic drug research. The problem is the FDA is still looking at this as psychedelic-assisted psychotherapy or some kind of that the psychedelic trip is necessary here. And yet you and I are talking about there are these second-generation psychedelics that don't cause the trip that are being looked at. And I guess, Steve, ultimately, the best way to settle this debate is to do a head-to-head randomized clinical trial of the second-generation drugs that don't cause the trip versus psychedelic-assisted psychotherapy and see who wins, what happens.
Exactly. And that'll be very hard to do, of course, because of the variance. It's always hard.
Right.
It's one thing for a drug to beat, or a therapy to beat placebo, but it's another thing for it to beat another active therapy. And the problem with the psychedelic-assisted psychotherapy is that there's no such thing as a placebo. And so you're going to be biased. People are going to know they're on the psychedelic, and they're going to know that when they're not on the psychedelic. And that bias has to be incorporated in interpreting the results.
Well, of course, Steve, you're 100% right. There's no way to blind psychedelics, at least the ones that cause the psychedelic trip. So it's really going to be hard. And as I said, there's politicization going on. There are people who have very strong opinions on this. In some ways, it almost reminds me of the genetic testing issue. I still get asked. I just literally, the other day, I was in a doctor's office talking, and I got asked about genetic testing. What do you think of genetic testing? I believe in it. I use it. And some people think it doesn't really do much at all. So it's that kind of thing. I think people are going to be invested in this, and they're going to have their own beliefs, belief systems. Some have become self-fulfilling prophecy. You see somebody do well, it reinforces my belief that this is the way to do it.
Yeah, I actually think that's a very likely outcome, particularly if we don't end up having drugs that can be administered safely, chronically, and without these hallucinatory side effects. Then what will happen is that I believe the psychedelics will exist. You can get some psychedelics, from, like you say, mushrooms. What is it? Our Treasury Secretary was given these mushrooms in a recent trip to China, but they cooked them and they said it took all the psychedelic stuff out of it, and she didn't have any experience. That was kind of interesting. There's psychedelic DMT in the skin of certain toads, so you can be a toad licker, except the problem is the DMT is not very well orally absorbed. And as you know, in ayahuasca, a lot of this has to do with, the lore and the clinical setting of that. But there are two roots involved with ayahuasca. One root has DMT in it. If you take that in your brew, it won't work. You have to take the second root from a different plant, and that one has harmine and harmaline in it, which are MAO inhibitors. So if you have MAO inhibition on board, then it allows you to have absorption of the DMT, which is why the T is the combination of these two roots. And so you will get DMT coming into your head, and you'll have the hallucinatory experience. And of course, the way that people cook this depends upon the ratios of those things and the doses of those things and different parts of the Amazon. I don't never maybe told you this, but I went to the Amazon to actually go to a medicine man, except that was a medicine woman. And so she was in there, and I didn't want to take the ayahuasca, but I wanted to watch. And so, but she came in there, and she was smoking, I think it was a tobacco cigarette, and she kept blowing it in my face as part of the ceremony. And, she's had these two different cauldrons on the stove cooking, putting the roots in there and, taking various ratios of one versus the other. And, maybe she's got a different ratio than the cook down the street. And so the different hallucinatory experiences are going to be based upon the combinations of the drugs. So there's a lot of background to this. It's been going on, like you say, for centuries. And so now it's time to get serious about it. If this is a treatment, then we really need treatments in psychiatry. And if PTSD can be treated by, if it's not psilocybin, by ecstasy, then, God bless ecstasy. Let's use it. But if it requires some sort of a behavioral state in order to do that, it's going to be very difficult to reproducibly induce that and to do it in a safe manner. So it's just, maybe it's more of a hope than actually the data yet, but I hope that the psychedelic experience is not necessary, because I fear that if it is necessary, it will be largely unregulated, and it will be basically the province of 21st century medicine men and medicine women in the United States who use it possibly in various charismatic ways, but not very regulated ways. I'd rather see a drug come out of this.
Steve, there's the idea of the ritual here, that a lot of times things accompanied by rituals are therapeutic and can be soothing and reassuring. And, there might be some mandated ritual associated with this if, for instance, a certain protocol, a certain way of delivering this gets approved. But it is important that we point out some of the controversies, and we point out the fact that there is ample evidence of neuroplasticity independent of the psychedelic experience. Although, as you've wisely said, Steve, every form of psychotherapy is biologic, does induce neuroplasticity, if you will. So it might be hard to disentangle these things.
Well, it gets you into something, I don't know if we ever had a podcast on it, but the placebo effect. What is, if a belief in something can actually, you can make people get better with placebo. There's no question about it. Whether it's enduring or it's a real, quote unquote, you can debate, but placebo responses is something that we do not understand very well. And is this an enhanced placebo response? And not to trivialize it to say, well, placebo is baloney and it's nothing to it. No, the placebo is real. Right. Maybe this is a good placebo effect or enhanced placebo effect. And hey, look, if a patient's got PTSD and they're having flashbacks and, re-experiencing and they have a horrible life and they're better, I don't care at some level. I want it to work.
Exactly.
And so if it's a form of enhancing placebo effect and minimizing what you'd call nocebo effect, which are, having bad side effects from an inactive substance, then it's the belief that is driving the therapeutics. Well, that's fine if that's what it is. But then don't call it a 5-HT2 drug.
Well, it's hard to disentangle that too, as you said. And, Steve, that's a great idea. We really should do a podcast on placebo. We do know a lot about it. And we know, for instance, that placebo effect is real, as you said, and you can demonstrate real biologic changes. If you do neuroimaging, you can see things happening in the brain. And then your point about expectation bias, the single biggest determinant of how well you do with any therapy is your expectation. If you expect to get better, you probably will. And the other thing, of course, as a longtime clinical trialist, and I know you've done lots of clinical trials too, I always joke that in the real world, placebo's my friend, as you just said. If that gets you better, great. But in clinical trials, it's my mortal enemy. And so we try to minimize it. But the fact is, placebo response does wear off typically. So it's not an enduring thing, but it's a sugar high. It can help jumpstart things.
So it's a matter of us trying to disentangle that. I think it's going to be probably, around for another decade while we're sorting this stuff out as we get different pharmacologic tools, as we get better handles on how to control the expectancy effects and the placebo effects, if that's what they are, or the real ritual effects that are part of the ritual that is necessary and sufficient for an outcome to occur. We don't do 4 hours of psychotherapy, so that's going to be a very interesting paradigm shift. If it works, then
you're right.
Doing 4 hours of psychotherapy over 4 months and not having it work, it should be rejected if doing 4 hours of psychotherapy in one afternoon works. So I'm all in favor of anything that works.
Right. And of course, there are significant legal and regulatory issues that have to be worked out here, as we've talked about. This also reminds me, Steve, of this really funny paradox. Marijuana in some states is completely legal for recreational use, and yet it remains Schedule I federally. So federally, it's illegal, but in certain states, it's legal. We're in this weird legal Neverland, or Netherland. And the same may happen here, unless something happens with the scheduling.
I don't foresee that, actually. I think that the same thing is going to happen. You'll have dispensaries for psychedelics as similar to the way it is for cannabis right now. And if that's okay, then we just need to regulate what you do with it. I'm a little worried about having it available because it does look like 5-HT2B chronic treatment can wreck your cardiac valves. And it's not a good thing to do. And also these post-treatment hallucinatory experiences where you can actually, people who take a lot of hits on LSD can start having LSD hits without even a hit, if you know what I mean. They just all of a sudden have a flashback and a hallucinatory experience without drug in their system. So we don't know what that is. Do the receptors change? Is the drug really still around and hits the receptor again? Who knows? But those things are important to do if it's going to turn into a drug.
Right. Yeah. Boy, that would be a bad thing if you were driving and that kicked in, I'll tell you. So, you're right, Steve. I mean, in Oregon, psilocybin is now legal. And again, there's this paradox. Psilocybin is a Schedule I controlled drug. The federal government says there's no therapeutic use for this. I imagine some states are going to want to do it like alcohol. They'll tax it and make money from it.
Well, I hear that Australia has a very powerful lobby that it's, I don't believe, yet legal, but there is a big move and lots of pressure on lawmakers to make it legal in the whole country of Australia, for example.
Well, this is something that's going on all around the world. You're exactly right. And around the world, people are having to confront this and figure it out. And as this data keeps emerging, these are definitely effective treatments. I don't question the efficacy of these things, but I think what we are questioning here is how they're efficacious, why they're efficacious, what's really going on here. And of course, it takes us back to the original era of psychopharmacology. We had no idea how our drugs worked. Essentially, we just knew they worked. So maybe that's where we are. We're at the beginning of this.
It's worth stating here that in this era of DEI, diversity, equity, and inclusivity, these are all going to be cash psychotherapy experiences for the rich, and so, or for the very desperate to raise money. It's not fair. So, if we're going to have these things that come, that's the reason for putting these things into a scientific context is to get them paid for if they work. Otherwise, we're going to have rich people who get access to therapies that the others don't, and that's something we've been fighting for a long time.
Well, I think you bring up another point, Steve, that some people are desperate, and they may try these things, just like some people go to Mexico and get unproven therapies for cancers and things. So this really does need to be regulated. We need to know how to monitor. We need to understand the risk. I think your point about 5-HT2B agonism is extremely well taken, because as we know, some of these drugs are promiscuous. They bind to several serotonin receptors, not just 5-HT2A. And I also loved your point earlier, Steve. I think we should emphasize this. We're in an era now where we're really talking a lot about what's happening intracellularly. We used to focus on the extramembrane receptors and things and what was going on out there. But I think it is very complicated. And the idea of biased agonism, where we can actually maybe change the direction of the signaling, and that does different things. So this is a fascinating new era. As you said, we're in this third wave. It's a very sophisticated wave of psychopharmacology.
Right. So we're being, sort of questioning and maybe a little bit cynical or even critical of some of these approaches, but I don't want us to throw the baby out with the bathwater. Is that there's something here. We are seeing a therapeutic effect. What it's caused by, whether we can reproduce it, shape it, and make it safe, and figure out how to bottle it for the general practitioner to use, those are the next sets of questions. And it's only in that spirit that we're trying to say, how do we actually bring these things forward and use the science to make sure that it's a real therapy?
Well, Steve, another thing we didn't really delve into is the fact that these things are being studied for a wide range of indications, and that's a little concerning too. I mean, I've seen protocols for eating disorders with psychedelics, for anxiety disorders, PTSD, as you mentioned, depression, ADHD. There's a drug being studied, which I think that's a real stretch, but I saw it.
Well, end-of-life anxieties, smoking, addictions of all sorts. So, it's lots of different things out there. So, part of me gets to the point of saying, that's good, but then also, is this psychiatric penicillin? It's everything, that ails you. You can take it for. It begins to believe not believable.
Well, it's like marijuana. I mean, we have people who use cannabis and swear by it, and yet the research has been very underwhelming so far. Now, it's possible there are subsets of people who do well. There's just a lot to figure out and a lot to learn here. But if it's deregulated, as you've said, or if it's really legal and easy to get your hands on, can be given in dispensaries, just like with marijuana, we're seeing some real problems out there, and we could see some real problems here. We've run out of time for today's episode, but I do want to encourage everybody to come back, listen to the podcasts in the Psychopharmastahlogy series here at NEI. We have a whole variety of them. We've been doing them for a couple of years now. So I want to thank you all for listening. Hope this was provocative, interesting, and ultimately perhaps helpful to you and your patients. And for more information, please go to our website, which is NEIglobal.com. This is Dr. Andy Cutler signing off. Thanks. Thanks, Steve.
Bet.
Thank you for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.